in thinking with the conference theme, which is priorities for the future, I'm sort of going to orientate this around three of my own personal priorities, which are honouring harm reduction expertise, researching with people, not on them, which is sort of pretty obvious really, which then can enable us to broaden the conversation. And I'm interested in here in looking beyond risk and beyond bloodborne viruses, and I'm going to talk about examples of those. And this can enable us to capacitate change in some really interesting ways, working in collaboration with communities. And I really like what Roy said about pragmatic research. I feel like, you know, that's where I'm at right now. And I'm going to draw on my own experience and research as a case study. And I actually bit off more than I could chew in preparing this. I wanted to present on everything. And so running through it last night, I realised I had to do some dramatic cuts. So I'm just going to skip through these. But they're all there on the slides, and I can talk through them later if you're interested. But I'm going to go on to a personal introduction. You know, why I'm here talking about peer involvement. And, you know, and that basically my personal history has informed my research focus. And for my 20s, pretty much all of my 20s, I was a dedicated injector in New Zealand, where it's quite a hard job being a dedicated injector, actually, of heroin and anything else I could get my hands on. And when I got Hep C, as you do, and when I stopped using, I was implored to go on treatment, which at the time was interferon. And I was very anxious about this and had a lot of dilemmas, including around disclosure. And so this really motivated my first research project when I stopped using, went back to university, etc. And I'm still doing it now. It's basically all, you know, selfish personal curiosity. But, you know, it's also influenced my approach to research practice, which is very influenced also by a feminist epistemology, which is about giving back, which is about bringing some of yourself into the research encounter. And I think working with people who inject drugs, that's particularly important for me because it's such a stigmatized condition. You know, if there's anything I can do to reduce their anxiety about being judged, then I will do it. And so for me, that is important. Now, I've also included this slide because about this time last year, I was invited to go back to New Zealand to talk at the first harm reduction conference in New Zealand. And for me, that was really moving and a real honour, particularly as it was put on by the New Zealand Needle Exchange. And in my 20s, in my early 20s, I worked as a volunteer at the Dunedin Needle Exchange, Devo. It was peer-led. In the weekends, you'd walk there and there'd be billows of pot smoke coming down the stairs and all sorts. And you know, and anyway, I've included this really because the sense of, you know, making good, moving to the big smoke, but nothing much actually having changed, and this feeling that it's sort of uneasy disjunction between am I a peer, am I a researcher? I'm not really either of them. I'm in this sort of weird nebulous place in between. And so, you know, in order to try and marry that up and honour my past, you know, I've continued to work with people who inject drugs. And in doing so, you know, and sort of honouring that and being who I am, I guess, it helps to facilitate a sense of identification and trust. And, you know, in my first research project, I had no money to give participants. It was actually for my master's, but I had to turn people away because I disclosed that I had hepatitis C at the time I did. And there were so many people desperate to talk to somebody else with Hep C. They hadn't had that opportunity, many of them, in their lives before, and most people were ex-users and completely in secrecy about it. So as Claire said, you know what I've been going through. Even though we have totally different lives, we're still connected by that virus. And in a later project around injecting drug use, Kyle says, you know, the good thing, you're an ex-user, you know how it feels. Like if you've been a normal person, God forbid, it would have been harder for me to break out and tell you how I felt. Now, often I don't necessarily disclose, but it's interesting is that people will guess. And I'm sort of like, oh, what's going on here? So an example here with Ben, in the middle, I said, oh, you know, well, I'm an ex-user. And he said, yeah, I'm not being horrible, but I could tell. And I'm like, oh, what was it? You know, I'm like, oh, is it that obvious? But I think that this is he's saying, you know, it's just the way you reacted to the way I'm speaking. And there's a sense of an embodied connection there, which can be challenging, but it can also lead to great insights. And I think I could have perhaps titled this, this talk about, you know, a fascination with veins, because really that's what it's all about for me. As an ex-user, I know how important veins are and how important veins are to people who inject drugs. And we will notice each other's veins. In the interview encounter, one participant said to me, "Oh, look, you've got a massive vein there, bloody hell." You know, and it's also confronting for me doing this sort of research and talking to people about these things. Like I wrote in one of my field notes when I first started in London, that I dreamt about trying to get a vein. You know, it was awful, the desperation growing with each attempt, and that I felt that that had been triggered by interviewing a guy that day where I could see his injection attempts on his hand, like I said, desperation writ large on the flesh. But, you know, it also enables insights and connection and broadens the conversation in perhaps unusual ways. So, for example, in the Staying Safe project, which was looking at hepatitis C prevention, we found that people who stayed safe from hepatitis C were largely motivated by pragmatic concerns around venous access. So they were using sterile needles, not because they were sterile in order to prevent bloodborne viruses, but because they were sharp and they were going to keep their veins going. You know, so as Giles says, you know, people would rather use clean works because they're sharp for a start, they're not going to be blunt. But does the message get through? Hep C, so what? I'm not going to drop down dead tomorrow. So this is a different priority. And this sort of embodied connection, my role as a peer, so to speak, or this nebulous in-between place, enables me to have had these sorts of conversations. And I want to say, and I said it better in all the slides that I skipped, that this is not to say that this is somehow better research or I'm getting some sort of honest answer because of my background. You know, it's just a different dynamic. That is all. And every researcher brings with them their own history and their own, you know, embodiment, which then creates a different narrative. There's not one that's better than another. This is just a different one. So, you know, we can, you know, my interest primarily is what matters to the people that I'm working with. And you know, that study, Staying Safe, was around hepatitis C. And I was talking to people, you know, it was a hepatitis C study, they knew that, but they were constantly pulling up their sleeves, pulling down their pants, showing me the sorts of wounds that Roy illustrated, you know, and this was what was important. And this is where they felt that they actually had nowhere to go. And so that is what's motivated me, and this is what my current project is actually looking at, but it stems from that. And, you know, I think we find that research for people who inject drugs tends to prioritise bloodborne virus transmission and treatment, particularly at the moment with this elimination agenda. And possibly because of that, that's why I've chosen to move away from that field. I'm interested in looking at beyond bloodborne viruses. And thinking about how you can best honour the expertise of the people you're working with. So, you know, again, research in the drugs and harm reduction field tends to focus on risk and health harms. And this can inform how questions are asked and also how they're interpreted, and then inform the sort of recommendations which may be based on, you know, educating people or changing behaviour. And also I'm interested in looking beyond risk, because this can lead to overly narrow interpretation. And an example below here of the sort of thing that alarms me is someone prominent in the hepatitis C field reporting on laboratory studies showing that use of injecting paraphernalia, such as cottons, water, cookers, etc., it does not transmit hepatitis C as much as we had previously thought, which is a good thing if it's true. But what scares me is the conclusion drawn from that, which is that needle and syringe programs may want to reconsider expanding scarce resources to provide supplies that will do little or nothing to prevent hepatitis C transmission. But injecting supplies are there for so much more. than just disease transmission, you know, and I think this is absolutely fundamental to remember. And this is why I'm very interested in broadening the conversation and challenging some of these dominant narratives. And so I'm just going to give an example of a project I'm currently working on, which is called Care and Prevent, which is the aim is to improve skin and soft tissue infection, prevention care and treatment interventions for people who inject drugs, the sorts of things that Roy was showing you the pictures of. And it has another part to it as well, which I won't go into now, but just to highlight the research question number 3, which is like, how do some people inject drugs avoid chronic skin and soft tissue infections, and what can we learn from them? So this is a different type of question that's around protection and care and honouring the expertise of people who are trying to look after themselves in constrained circumstances. So this is my first mixed method study, so it's like, oh, I've actually got some quantitative data because I'm a qualitative researcher, but we collected survey data, really extensive survey data with 455 people who inject drugs in London. And I just want to highlight here, you know, that it is a very marginalised population. 78% report ever rough sleeping, street homelessness, with a median duration of 4 years. And nearly half are currently in a hostel or street homeless, and the majority injected heroin or heroin and crack cocaine. There's a large proportion with skin and soft tissue infections, such as abscess and cellulitis, significant delays in seeking care. Many people wait for more than 10 days to seek medical advice, and this can actually be months. But what is interesting is a large proportion reporting hospitalisation, you know, for things that are really treatable that shouldn't be hospitalised. And, you know, a lot of comorbidities amongst this population, and these are just diagnosed conditions. And I guess what I wanted to highlight here, and this is a very messy slide, it was something else, I was trying to work something out, but that 27% of people with a bacterial infection, abscess or cellulitis, report septicemia, and they would have been hospitalised for this. And this is, you know, this is delays in care. This is serious stuff. And you have 7% reporting endocarditis, you know, which is scary. And I think some of this and unpacking what's going on here can also give us some insight into increase in drug-related deaths amongst this ageing population as well. So I was interested in looking at beyond the numbers, you know, what's going on. And here in the qualitative interviews, I again focused on protection as well as risk. And, you know, I asked people to describe a typical day on the street and things like this. You know, it's really important to be attentive to context. And I think, you know, in this slide here, there's nothing new. We all know that street injecting is characterised by opportunity, urgency and constraint. It's a difficult environment to use drugs in. You're constantly wondering, you know, if the police are coming, there may be unhygienic environments, violent architectures like blue lights, which actually reminded me when I walked in here, I was like, oh, so no injecting while the people are speaking, right? You know. But what did surprise me, and this is an example I want to give of environmental constraint, what did surprise me was that people talked about their injecting practice. Now, I asked in detail about how people prepared their injections. The majority of people I spoke to used heroin and crack together. And so, and I have this up here just to illustrate that before people add the crack, they all described adding a bit of cool water. And this is important because of what was described as water, okay? So the water people talked to me about using in their injections included tap water, bottled water, puddle water, surface water on cars, water from a toilet system, also whiskey, beer, cider, Coca-Cola, lemon juice, and saliva. Now, I wasn't expecting that. And if I had, I would have included it in our survey. But, you know, this is a learning process, as always. And I think a great example of environmental constraint is here with James saying, you know, we were on the streets, it was a red hot day, there was no water anywhere, and I was dehydrating. Plus, there's no toilet, no taps anywhere, no rain, no nothing. I was proper sick for a hit. In the end, because I couldn't find no water and my spit wouldn't work, I had to do it with a puddle of water. Now, James was lucky, actually. He described to me his spit not working, it fizzling up when he tried to make the injection. Eddie was less lucky. His saliva did work. And as he said, I got the worst infection of my life. I nearly died. I was in hospital for nearly 3 months. As you all know, bacteria, saliva is full of bacteria. It's incredibly dangerous to inject it. And there's no water in injection packs through pharmacies in London because it's too expensive. So how much did one Eddie cost, right? And this sort of thing makes me incredibly cross. It's something I want to try and do something about. And I'm interested in what people do to navigate, constraint in these circumstances. How can we honour and learn from their expertise? And James, who was the guy before, gives a really poignant example of self-care. Again, it makes me angry when people say, oh, people who inject drugs, they don't care. They do care. If you give them the opportunity to use clean water or dirty water, what do you think they're going to use? And here James is trying to make the puddle water clean by filtering it through an alcohol pad, which, just makes me feel really sad. Sally is a great tip for people who are on the streets, is that she asks people when she's begging to buy her a bottle of water. And I think this is fantastic advice for people who are street injecting and begging. Ask people to buy a bottle of water. Ask for 2, one to drink out of and one to use for your injections. So in terms of, getting our focus back to the point of the talk, which is about veins, of course, I think, for me, vein damage is at the core of a lot of these health harms. And I'm really interested in why people in the UK are losing their veins so quickly. And this interest is born out of my own experience as a user in New Zealand, where, I injected my arms for nearly 10 years and it was fine, no problem. I come to the UK, people were saying they're losing their peripheral veins in their arms after about 6 months. What is going on here? What is the story? And Sal gives a good example of, difficult venous access leading to abscesses, all these other things. A lot of the health harms that Roy showed were around, desperate injection attempts. You're only having a desperate injection attempt because you can't get a peripheral vein. All right, and so what is different about the UK, and my hypothesis is that it's to do with acidifier and that people are using too much acid in their heroin preparation. And so that most people here, as Mason said, think a sachet is for a bag, and there's a variety of reasons for that. And, because of my nerdy obsession with veins and trying to understand what's different about the UK and other countries, for example, we asked a lot of questions in my project about what sort of acid you use, how much you use, hypothetically, how much would you use if you're cooking up a 10-pound bag, etc. And we found that most people use too much. And in a previous study, we tested some heroin solutions with a fancy pH meter, and we found that people in London preparing heroin with citric were injecting something akin to the pH of vinegar, way too acidic. So, how can we capacitate change? What can we learn from this? All right, now I'd love to be able to, have big changes, have drug consumption rooms, safe injecting sites in every borough. But, I can't quite do that just by myself. But what I can do is try and get citric package reworded. And we've done that, which is a really nice step. Because, a lot of people talked about using a whole sachet, which is way too much. And it's not helped by the wording on the packet saying this is a single-use sachet. I also have real problems around sort of the warning injecting citric acid damages veins. That's a shaming message. That's what people are using the acid for. So it's not helpful. And so Exchange Supplies wonderfully have reworded this in collaboration. So it's add citric slowly, use as little as possible, start small, a whole sachet is far too much for most injections. So it's a small change, but it's a start. And again, they've redone their water poster, they've added in stuff about saliva, puddle water, they've reorientated the risks. And what I really like about this also, this isn't just best practice, always use sterile water, always use this, which can be completely alienating, as is advice to wash your hands. If you think about it, people who are having to, use puddle water for their injection, how do they feel if they're being constantly exhorted to wash their hands before they inject? It's actually shaming and alienating. So what I believe in is providing, hierarchies of care, hierarchies of safety. If you can do this, if you can't do that. And this is a wonderful example. So I'm just going to I know I haven't got long, but I want to also talk about what the next thing is that I want to do. Those are small things. I'm going to try and advocate for water to be brought back into injecting packs in the UK. So that's a slightly bigger project. But what the qualitative data brought out are people are living with severe pain. They're incorporating severe pain into their daily lives and huge delays to seeking healthcare, which are leading to massive health harms such as this. And why are people delaying going for care? This is probably not surprising to anyone, but it's around stigma and it's around fear. And there is something that we can do about it. And one of the big fears is around being hospitalised and in withdrawal. And a lot of people tell me they have to wait, an insufferable amount of time to get their opiate substitution therapy if they're in a hospital. They're in huge fear of being in withdrawal, which leads them to feeling that they have to obtain adequate money or drugs before they can even seek care in case they're made to be an inpatient. And if people are living hand to mouth or injection to injection on the street, trying to get a stash of money or drugs to take into hospital with you is a pretty difficult ask. And so often what happens is they end up being collapsed and an ambulance is called by somebody else. And self-discharge while in withdrawal is really common as well. So this is a really corny title. We're going to rename it. And I've been doing some groups with people who use drugs and they're like, yeah, it's a corny title. But I'm trying to think, what can we do to help people get their medication? And in groups with people who are using, they're saying, yeah, a card that we can take in that has a quote from the Orange Guidelines, try and get endorsed by Public Health England, try and get some other endorsements, have the key workers sign it off, and Release, who are a great organisation providing legal advice, they're on board with me, and they've actually sent out freedom of information requests out to all hospitals asking about their opiate substitution policy. I'm totally on a roll with this one. I'm just going to go for it. And that they're going to, will provide a release number and try and do something around this. But, like I said, this is just a small start. Where opiate substitution therapy on the critical medicines list needs to be changed. So again, it's really interesting looking into all the structural barriers here and thinking about, but they are all modifiable. If we identify where the problems are, we can try and do something about it. And I just want to close on this and saying people are incorporating severe pain into their lives. And I want to think about this in the broader context of living with multiple violences on a daily basis. Physical violence. I have so many people saying things to me like, I've been set alight in my sleeping bags, I've been battered, nearly kicked to death, had it all. Structural violence, including from helping services. This guy saying, because I'm on the streets, they're saying, well, I'll just stick there basically. Since I came out of the coma, I've had no housing, they kicked me out of hospital, no psychiatric help, my mental health, nothing really, no support. I'm trying, but no one's catching me. No one's holding me a lifeline. Which can lead to, a symbolic internalized violence. People saying, internalizing these stereotypes about themselves, saying, of course I'm a junkie, I'll wait to the last minute. And, this big guy who I interviewed had huge scar across his throat saying, I had enough, I slit my own throat last September, gone. An incredible desperation, which is, I find, absolutely heartbreaking. So I guess I just wanted to reflect on all of these issues and think about, you know, how we can honour expertise in our work, how we can be alert to what matters to the people that we're working with, and thinking about broadening the conversation, looking at what people are doing to look after themselves in constrained circumstances, to honour that and learn from that as well, instead of just focusing on deficit and risk. And then working with in community of collaboration to make changes, however small they may be, in terms of things like redesigned citric packets, to actually bigger changes like trying to get opiate substitution therapy redesignated and put on the critical medicines list. Okay, and so that's me. Thank you very much.